This is a lecture on urinary tract infection. At least 20% of women develop UTIs during their lifetime, and that's more than 100,000 people that are usually hospitalized with UTIs annually. More than 15% of the patients who develop gram-negative bacteremia can die from this, and this 1/3 of these cases are caused by bacteria that originate in the UTI tract. Although fungal and parasitic infections may also cause UTI, they are uncommon. Upper versus lower. Lower urinary tract, usually no systemic manifestations. Examples such as cystitis, which is inflammation of the bladder, urethritis, which is inflammation of the urethra. Urosepsis is a UTI too that has spread systematically, and this can be life-threatening. So a patient who has this may require emergency treatment. And then you have uncomplicated UTIs that occur in otherwise normal urinary tract, and they usually involve only the bladder. Complicated versus uncomplicated. When we talk about complicated UTIs, they can coexist with the presence of obstruction, stones, catheters, diabetes, some other form of disease process. The patient that has a complicated infection. A common factor contributing to the ascending infection is urologic instrumentation. For example, catheterization, cystoscopes examination. Predisposing factors, examples are obesity, as far as anatomic, obesity, congenital defects, fistulas, and then compromising immune response factors are stuff like HIV, diabetes. Most infections are due to gram-negative bacilli normally found in the GI tract, although gram-positive organisms such as strep or enterococci can also cause urinary tract infection. Defense mechanisms, what we have in our body, we have acidic pH, urine is slightly acidic. We have high urea concentration, and we have abundant glycoproteins, and these all serve as defense mechanisms. Lower urinary tract symptoms are experienced in patients who have UTIs of the upper urinary tract as well as those with the lower urinary tract. The urine may contain grossly visible blood, which is called hematuria, or sediment, which gives it a cloudy appearance. So when you have hematuria, you can have gross where the patient can see, or you can have microscopic where the patient can't see it, but the blood is in there when they do the urinalysis. These symptoms are, defined in your text, but nocturia is waking up 2 or 3, or more times a night. Nocturia in enuresis is the loss of urine during sleep. Bladder emptying, you can have issues with weak stream. You can have hesitancy, where you see that more with prostate issues, where you have a difficulty starting that urine stream. Bladder emptying, as far as that, you have intermittence, which is an interruption of the urinary stream during voiding. You can have post-void dribbling. Urinary retention, which is the inability to completely empty the bladder. Dysuria, which is difficulty voiding. And people with significant bacteremia may have no symptoms, or they may have non-specific symptoms such as just fatigue or anorexia. Because older adults are less likely to experience a fever with UTI, the body temperature as an indicator for UTI is not really reliable with older people, so it's kind of non-reliable. In a patient suspected of having a UTI, initially we do dipstick urinalysis to try to identify the presence of nitrates, which means that there's some bacteremia in the system. We do look at white blood cells. We look at leukocyte esterase and that's an enzyme that's present in your white blood cells that indicates pyuria. And these findings can be confirmed with a urinalysis. A urine culture is indicated for complicated UTI or persistent bacteremia, or people who have frequent UTIs. Urine can also be cultured when the infection is unresponsive to emptying, to therapy, or the diagnosis is questionable. For women, we teach them how to, spread the labia and wipe those areas of the periurethral area from front to back using a moistened, clean gauze sponge. No antiseptic is used because it could contaminate the specimen. So, we teach them how to do a clean catch. We also tell them to keep the labia spread apart during the collection for 1 to 2 seconds after the voiding starts before they start collecting. For men, we instruct them to wipe the gland penis around the urethra, and this specimen is collected 1 to 2 seconds after voiding as well. Refrigerate any urine specimen on collection, and then of course there are other tests that we can do to look for further issues with the urine system. The collaborative care and drug therapy of infection. Many residents of long-term care facilities, especially women, have chronic asymptomatic bacteremia. So we usually, however, is usually only symptomatic UTIs are usually treated, because if they don't know the patient have it, they usually don't treat it because the patient's asymptomatic and they're not looking for it. Bactrim, Septra, macrodantin, those are your treatment of choice. Uncomplicated cystitis, a short-term course, where complicated, maybe 7 to 14 days. Macrodantin, or trimethoprim, is given 3 to 4 times a day. It's a long-acting PrEP. Like macrobid is taken twice a day. Ampicillin, amoxicillin, your cephalosporins, they all treat uncomplicated UTIs. Subjective and objective data, we should obtain this from our patient, especially when they have a UTI. UTI is what they're presented with. Health history, look for nausea, vomiting, anorexia. We look for, frequency, urgency. So we're looking at the urinary hygiene. If they're on antibiotics, what have they taken? There's plenty of things over the counter, so we need to look at those. We need to know if they're pregnant. We need to look also at STIs because they can mimic some of the urinary system. Objective data, fever, hematuria, having a funky smell to the urine, tender in the area when you palpate. They can have enlarged kidneys, which can show up on scans. So we look for, in the urinalysis, leukocytosis and positive findings that can indicate infection. Your nursing diagnosis are pretty standard, issues with urinary elimination, and make sure they know how to self manage their health care. And the whole goal is to make sure they don't have any symptoms. You want to relieve them from the symptoms. You want to prevent it from spreading to the upper urinary tract. As far as home care, we do want to make sure they understand that they need to comply with the drug therapy. They need to maintain adequate liquids. And we teach them to go to the bathroom every 3 or 4 hours. As nurses, we don't do that, but we need to do that. Void after intercourse. You need to get up and void. It prevents the bacteria from traveling. Acute pyelonephritis. This is inflammation of the parenchyma in the renal area, and then it's a systematic infection and a sort, and it can lead to septic shock. It can lead to death, especially if it's unresolved bacteremia. So it can be caused from bacteria, fungi, protozoa, viruses. So you need to be aware. Again, for regular patients of long-term care facilities, urinary tract catheterization is probably the most common cause of pyelonephritis. So you have to look at that, because usually your pyelonephritis begins with a colonization of infection of the lower tract, and it ascends through the urethra. Again, different bacteria can cause it. The symptoms with it are, flank pain usually stands out with pyelonephritis and chills. Even though the other symptoms are UTI symptoms, you can see those with, a lower urinary tract infection as well. Diagnostic studies, urinalysis results can indicate pyuria or bacteremia and, different degrees of hematuria. Your WBC can be looked because they can be found in urine as well, which means it can be some involvement with the renal parenchyma. A complete blood count will show leukocytosis and a shift to the left with the increase of neutrophils or the bands. And neutrophils, when they're talking about CBC and they're talking about bands, they're talking about neutrophils. And then they can do ultrasound of the urinary system to look and see if there's anything anatomic going on, like obstruction or some abnormalities or some hydronephrosis, or abscesses or stones, that type of thing. And then, of course, they can do CT scans if necessary as well. The diagnostic tests in the collaborative therapy of acute pyelonephritis are, looking at that sign and symptoms, because they can be treated on outpatient with antibiotics for 14 to 21 days if it's mild. If it's more severe, it may require hospitalization and IV antibiotics. Reinfections for people who have been treated with episodes can occur, and they usually have to manage them with long-term therapy. And sometimes they may have to give them a prophylactic antibiotic as well, or something that, something like trimethoprim over a course of time. Subjective and objective data that should be obtained, even, because keep in mind, it's going to be similar to UTI, pyelonephritis, all going to be similar. So it's still going to be the same thing. If they're pregnant, if they have retention, if they have a history of stones, if they have STDs, because you want to look at, or STIs, depending on what book you're reading. And then we look at the antibiotic treatment and what type of urologic instrumentation, do they have catheters? What's going on with them? Teach them the proper hygiene. Nurse and diagnosis, again, are acute pain, impaired urinary elimination. So early treatment for cystitis to prevent infections from spreading to cause pyelonephritis, and the need for regular care. They need to follow up with the culture when they get the culture done. These patients, we need to encourage them to drink at least 8 glasses of fluid every day, even after the infection has been treated. Okay, what urinary kidney stones or urinary tract calculi? We do know we have millions of people in here that have, nephrolithiasis. Depending on, that's a kidney stone. If it's if it's in the urethra, it's a urethral lithiasis. So the term depends on the location. It is more common for men to have these than women, and they do show increased incidence in people of with a family history of stone formation. We teach them, to keep urine dilute and free flowing reduces the risk of recurrent stone formation in many of the individuals. So we really want to, teach them that. And, the factors that affect that are, the genetic, the climate, the lifestyle. The higher the pH or the more alkaline, the less soluble are your calcium and your phosphate stones. So the lower the pH or the more acidic it is, the less soluble are the uric acid and the cysteine stones. So when a substance is not very soluble in fluid, it's more likely to precipitate out of the solution. And so we have to think about what type of stones that they're having so we can do the proper treatment for them. Genetic factors may also contribute to stone formation. There is a autosomal recessive disorder with cystinuria. So, because they have a marked increased excretion of cysteine, they can be more prone to those stones. This is just a picture of urinary tract calculi. There are different formations that they can have. They can look like they have spurs on them, and they can be just as smooth, as the baby's bottom. This is an example of a staghorn kidney stone. With a staghorn, it can cause hydronephrosis in the kidney because it can block that area. And removal can be, a large risk factor for hemorrhage. Types of stones: calcium phosphate, calcium oxalate, uric acid, cysteine, struvite or magnesium are stones too, or types of stones. Usually when somebody has a complaint of calculi or a kidney stone, they complain of severe pain due to obstruction. And it usually begins suddenly, all of a sudden. They may even hear the term renal colic, where it goes off and on, a severe pain that results in, from the stretching and dilation or the spasm in that area. Measurement of the urine pH is useful in diagnosing the struvite stone and renal tubular acidosis. Patient who form stones that are recurrent should do a 24-hour urinary measurement. They should look at the levels of calcium, phosphorus, magnesium, oxalate, citrate, sulfate, potassium, uric acid, anything that the stone could be formed out of. They want to look at that so they could determine what's the best course of treatment for that particular patient. Administer opioids to relieve the pain. Sometimes they may give Flomax and Hytrin. These are adrenergic blockers that tend to relax the smooth muscle in the ureter, so they can help with that stone's passage, so they may give that. These drugs can also relax the muscle of the prostate in men with people that have BPH. Drugs prevent stone formation in a various types of ways. They can alter the urine pH. They can prevent excessive urinary excretion of a substance, or they can try to correct the primary disease. Say if they have a hyperparathyroidism where they're, having a lot of calcium in the body. So if they treat that, then they can decrease the calcium formation of a stone. Now they can also do some other types of procedures for stone removal. They can do lithotripsy. They can do surgical stone removal, which means, but if stones are too big for passage the normal way, then they may have to do one of these surgical procedures. So they could do lithotripsy, where they actually go in and send sound waves and they actually shock the stone and break it up that way, because it bounces off the stone and breaks the stone into smaller pieces. Or they can do a stone basket removal, and they can go through the urethra and, grab the stone, put it in the basket and pull it out if it's small enough. If the stone is located in the bladder, they may have to do a cysto to remove that. They can do flexible ureteroscopes, where they can actually insert into the cystoscope. They can remove stones from the upper renal pelvis and urinary tract that way. For large stones, again, they usually have to be broken up, so that's where the lithotripsy may come in. The percutaneous nephrolithotomy is where they actually take a nephroscope and insert it into the renal pelvis through a tract. And usually through the skin, they go through the area in the back, and the kidney stone can be fragmented with like lithotripsy and broken up, and they can remove it. To manage obstructing stones, we do tell the patient to drink a lot of fluid to avoid dehydration. Forcing excessive fluids is not advised, because this has not been really proven to be effective. but they do have them drink the standard amount of fluid and increase if they're at risk for dehydration. They do have them increase that amount, that standard amount. Especially those people who are prone to stones and they're active in sports, they perform a lot of physical exercise. These people need to take a little more fluid than the standard. Diagnosis, impaired urinary elimination, especially if it's related to trauma or obstruction of the ureters. And of course, they're going to have pain. So they may have issues with pain control or comfort measures and knowledge deficit. Especially if they're unfamiliar with it, if it's their first time experience with stones. Adequate fluid intake is important to produce a urinary output, because you usually want to put out at least 2 liters a day. So moderately active or ambulatory people should drink 3 liters a day. If you drink 3 liters, then you should put out. Fluid intake will need to be higher in an active person, which I've already said, but or somebody who engages in athletic activities. Diet restriction and purines may be helpful, especially if they are at risk for uric acid stones. Evaluation, make sure you want to maintain a free flow of urine with minimal type of blood in the urine and have pain relief. The next section is prostate cancer. So we're going to start male reproductive health here. And keep in mind that, prostate cancer is, prominent enough that we need to discuss it, because it's affecting a lot of men. It's estimated by almost 500,000 new cases of prostate cancer every year. And about probably close to 30,000 men die annually from prostate cancer. Skin cancer is the most common cancer. Lung cancer is the leading cause of cancer death among men. The majority of cases occur in men that's over the age 65. However, many cases occur in younger men who are sometimes have a more aggressive type of cancer. So you still talking about almost a couple million of men in the world who are, now prostate cancer survivors. Spread by 3 routes. Direct extension involves the seminal vesicles, your urethral mucosa, the bladder wall, and the external sphincter. It also spreads through the lymph system, through the lymph nodes, and it can also spread through the bloodstream. And that can go to the pelvic bones, the femur, the lumbar spine, the liver, and the lungs. And you'll notice that prostate cancer, if it metastasizes, it usually goes to the bone and to the lungs. Risk factors, we know age is a risk factor, ethnicity and family history. Incident rises markedly after the age of 50. Median age is about 67. It's highest in men of African descent and specifically the Jamaican descent. If you have a first-degree relative with prostate cancer, it increases your risk factor. Dietary and obesity can be associated with prostate cancer as well. High red meats and processed meat intake, diet in high fat and dairy products, and diet low in vegetables and fruits. It's not clear if smoking is a risk factor, and it's not clear if having BPH put them at higher risk or not. If men have a family history of prostate cancer, they should talk with their health provider about their concerns, because it's important that they know so they can look at the detailed family pedigree and look at that. Depending on the findings, they may need a genetic counselor, may be appropriate for them. Symptoms are similar to BPH. So you have urgency, hematuria, nocturia, retention, interruption of urinary stream, and then they do have problems sometimes with the inability to urinate. So we have to be able to look at that. Sometimes, especially if it's in a more advanced case of prostate cancer, they may complain of low back pain that radiates to the legs, the bone, the pelvis area. Now, elevated levels of PSA, normal, are 0 to 4. And this is a glycoprotein that's produced by the prostate, and it does not necessarily indicate prostate cancer. Elevation can indicate infection or BPH, but it is our um, only marker that we have right now for prostate cancer. We do show a correlation with the higher numbers related with prostate cancer. Mild elevations in PSA can occur, like I said, with BPH, recent ejaculation, acute or chronic prostatitis, or even if somebody rides a bike and that prostate is irritated, or rides in somebody that drives big trucks, that they're sitting there bumping around, that prostate become irritated and inflamed, they can have mild levels, elevations of PSA. So, in addition, a cysto, indwelling catheters, biopsies can also occur. Biopsies of the prostate can also cause that PSA to have elevation. Proscar and Atavert can also cause the PSA level to lower, so you have to keep that in mind if they're on that medication. An elevated PAP or a prostate alkaline phosphatase is an indicator of prostate cancer, especially if there is extracapsular spread. With advanced prostate cancer, your serum alkaline phosphatase is increased as a result of the bone metastasis. So they tend to look at those serum biomarkers for prostate cancer. The DRE is a digital rectal exam. It's an abnormal finding to find it hard and nodular and asymmetric. It should be smooth like an egg, and it should be, be spongy until it should not be hard. Neither the PSA or the DRE is a definitive diagnosis test, but it's the best we have right now. So a biopsy of the tissue is necessary to confirm the diagnosis. So if those are abnormal, if the rectal exam and the blood work is abnormal, then they will usually want to do a biopsy. This is done by TRUS, a transrectal ultrasound, to allow the physician to visualize and pinpoint the abnormalities of the prostate. And they can actually go in and put and do it in the office, and they can go in with an ultrasound. It's the similar ultrasound that they do with females. It's the type of machine that they use with the females that when they do vaginal ultrasounds. So they'll put a protector over it and put it in the rectum, and then they'll put a little probe over it, and then they can put the needle through that and actually aim at the area and shoot the area of the prostate that they want to touch in biopsy. Early recognition and treatment are very important, because that's how you can control the tumor growth, and that's how you can prevent metastasis. If caught early, the chance of survival is 100%. And so 90% are initially diagnosed when the cancer is in a local area. So that's good. And then Proscar is one of the drugs that can be used to treat BPH, and it may also reduce the chance of getting cancer up to 25%. They have some research on that. Grading tumor is done by the Gleason scales. You have different grades. Grade 1 represents the most well differentiated or the lowest grade. And grade 5 represents the poorly differentiated, unlike the one that's unlike the original cells, or the highest grade. So 5 is the poorest differentiated and the highest grade. 1 is well differentiated and the lowest grade. The PS level at diagnosis and the patient's Gleason score are used to do that TNM system like we talked about in oncology. Surgical therapy is a radical prostatectomy. The entire prostate is removed because cancer tends to be in many different locations within the gland, so they'll do a radical. They can do it retroperitoneal. Lymph node dissection is usually done. They can do that type of procedure, or they can do a lower abdominal cut. Surgery is usually not considered an option for advanced disease because metastasis is. Now, because of the peritoneal approach has a higher risk for post-op infection because of location and it's so close to the anus. You have to be careful as nurses to be very good and clean with your dressing changes and your perineal care after bowel movements and provide comfort for your patient. The incidence of erectile dysfunction is dependent on the patient's age and preoperative sexual functioning. With nerve-sparing surgeries can be performed now, and the expertise, depending on the expertise of the surgeon, sexual function can follow surgery, tends to return gradually over the course of 2 years. And then, of course, we have medications such as Viagra may help to improve sexual function. But, when you have a total nerve loss, then even Viagra wouldn't help that. Problems with urinary control during those first few months is normal. You really have to let your patients know, because the majority of people that have a prostatectomy usually have a total loss of urine, incontinence issues in those first few months, and they usually gain them back, but they don't even know. It's like all of a sudden they're wet and they didn't even have the feeling that they had to go. Cryosurgery, they can do a transrectal ultrasound. They take a probe and insert it to visualize the prostate gland. The probes actually contain liquid nitrogen, and they actually can insert this into the prostate gland. And it actually causes the tissue to become destroyed because it actually freezes the tissue and it dies. Treatment can take 2 hours under general spinal anesthesia, and it does not involve a incision. There is some complications to cryosurgery. They can have damage to the urethra or the fistula, or tissue sloughing, erectile dysfunction, urinary incontinence, prostatitis, hemorrhage. All that can occur as well. Radiation therapy, external beam radiation. This is probably the one that's used the most with prostate and is used to treat cancer that's confined to the prostate gland. Patients are usually treated on an outpatient basis, usually 5 days a week for 4 to 8 weeks. Each treatment only lasts a few minutes. Common side effects are issues with the skin, because that's where the radiation is beaming down. Fatigue can also occur. Problems may lessen 2 to 3 weeks after the completion of radiation therapy. In patients with localized cancer, cure rates with external beam radiation are comparable to those that have radical prostatectomies. Brachytherapy is implantation of radioactive seeds into the prostate. This actually can spare some of the surrounding tissue, and they actually use a transrectal ultrasound probe to actually insert the seeds. The urologist gets in collaboration with the oncologist, and they can determine how many seeds that this patient needs. It's usually done on a one-time outpatient basis procedure. And many patients like this because it's very convenient and they have less issues with erectile dysfunction. Drug therapy, androgen deprivation is a pretty therapeutic approach that they use now. Is actually focused on decreasing the androgens to reduce the tumor growth. And usually what you see is over the course of time, tumors become resistant to the therapy within a few years, and elevated PSA levels are often the sign that they see that the therapy is not working anymore. There are 2 classes of deprivation therapy. One is androgen synthesis inhibitor, and one is androgen receptor blockers. Now, your luteinizing hormone releasing hormone agonist, with continued administration, your luteinizing hormone and testosterone levels will decrease, and it will produce a chemical castration similar to an orchiectomy. They can have side effects like hot flashes, gynecomastia, and loss of libido, and of course, erectile dysfunction. Now, luteinizing hormone releasing hormone antagonists, something like Degrelix, blocks your LH receptors. It is immediate testosterone suppression, and they can have side effects such as pain, redness, injection site issues, and problems with your liver enzyme. Chemotherapy is primarily limited to treatment of those with hormone-resistant prostate cancer in late stages. And usually with chemo, it's usually a palliative treatment. The cancer is progressing usually despite treatment, and this occurs in patients who have taken like an anti-androgen for a certain period of time. Some is more common than the others, as far as, the type of chemo. Um, but Taxotere, Abraxane, Cytazan, those are probably your more common ones, along with Zetigia. Orchiectomy is what they do. Testosterone stimulates growth of prostate cancer. We know that. So what you usually see is that they'll do a bilateral orchiectomy, maybe done alone or in conjunction with a prostatectomy, depending on the stage and what type of cancer. Because this can actually provide a lot of relief for the pain, especially bone pain. You have a lot of pain in the bone, and you have a lot of nerve endings in the bone. Orchiectomy can also shrink the prostate, and this can help with urinary obstruction issues. Nursing diagnosis, coming up with a decision on what's the best treatment can be an issue for them. Urinary elimination, sexual dysfunction, anxiety, all that can be part of the patient's issues that they can have. BPH, or benign prostatic hyperplasia. It's enlargement of the prostate gland, usually resulting from an increase in number of epithelial cells in the stromal tissue. It's probably one of your most common urologic problems in male adults. About 50% of all men will develop BPH in their lifetime. And the older you get, the higher the risk factor. Don't necessarily have a correlation with BPH and prostate cancer. This is just a picture of the male reproductive system. As far as the pathophys, there's no direct correlation between the size of the prostate and the severity of symptoms or the type of obstruction that they can have. But it is the location of the enlargement that's the most significant in the development of the obstruction symptoms. For example, it is possible for a mild hyperplasia to cause a severe obstruction. It is also possible for extreme hyperplasia to cause very few obstruction symptoms. It all depends on the location. Risk factors for BPH are age, obesity, especially if they have increased waist circumference, because then they have a lot more fat and areas in the abdominal area. Lack of physical activity, increased alcohol consumption, and alcohol, we know that it has a relation to prostate cancer as well. Erectile dysfunction, smoking, and diabetes. The patient's symptoms are usually gradual in onset, and they may not be noticed until the enlargement has been present for some time. So symptoms can be obstructive or irritative symptoms. Nocturia is often the first symptom that men notice, getting up at night to void. Obstructive symptoms usually due to urinary retention. They can decrease the caliber or the force of the urine stream. Their difficulty in initiating urination. They start and stop in stream several times when voiding, or they can dribble. Irritative symptoms are things like urinary frequency and urgency, dysuria, bladder pain, nocturia, incontinence. Acute urinary retention, complication with sudden painful inability to urinate. Treatment involves catheter insertion or possible surgery. Can have issues with UTI and sepsis, where you have an incomplete emptying of the bladder, and that residual urine provides a medium for bacterial growth. Calculi might develop in the bladder that can cause a more alkaline environment in the residual urine, which again increase bacterial issues. They can have renal failure, pyelonephrosis, bladder damage. Diagnostic studies using the DRE, or the digital rectal exam, the healthcare provider can estimate the size and the symmetry and the consistency of the prostate gland. In BPH, the prostate is usually symmetrical, but just enlarged and firm and smooth. A urinalysis with culture is usually done to make sure there's no presence of infection. PSA may be done to rule out prostate cancer, but keep in mind a mild elevation still can mean it's just a issue with BPH. And then they may order, BUN and creatinine to look at for make sure they don't have any renal issues. And then, of course, neurological exam can be performed as well. A TRUST is a scan that allows for accurate assessment of the prostate. It's very helpful in determining whether it's BPH or prostate. The biopsy would confirm that. Uriflow can be done. It's helpful in determining the extent of urethral blockage, and if they have poor dribbling. And then a cysto can be done to help diagnose and look in to see if they need something more, how big the prostate is. It can help see that. The goal is to restore, to make sure, is not based on the size of the prostate. The goal is in treatment is based on, making sure the goals are met, that the bladder's draining the way it's supposed to, that the symptoms are not there, and to prevent complications. Conservative therapy, they may use some active surveillance, and they can have a lack of presence of symptoms, and they can use the little the Association of Urology actually has a template that you can score and look at the scores from 0 to 7. Dietary changes, we may say, decrease the intake of caffeine and artificial sweeteners, limit spicy and acidic foods, avoid medications such as decongestants and anticholinergics, and restricting even in fluid intake. That may possibly help with some of the symptoms. A time voiding schedule may also help to reduce that. Reduce symptoms, so that may be something that needs to be further investigated with that patient. Drug therapy. There is drug therapy out there that can offer systematic release. Usually your 5-alpha reductase inhibitors or your adrenergic receptor blockers, or combination therapy of both can be used. Finasteride is probably appropriate treatment for individuals who have a moderate to severe symptom scores on the AUA guidelines. The drug has to be taken on a continuous basis to maintain therapeutic results. They look at PSA levels because they can be decreased by up to 50% with taking finasteride. Therefore, PSA levels should be doubled when comparing them to pre-medication levels. Your alpha adrenergic blockers are more commonly used for the treatment of hypertension. These drugs promote smooth muscle relaxation of the prostate, so you may see them used as well. Example of those, maybe Flomax, Cardura are probably your common two, and they can improve. Now, one of the erectile dysfunction drug, Cialis, is very effective with reducing symptoms of BPH while reducing the symptoms of ED as well. There are some minimal invasive therapies that can be done. They generally do not require hospitalization or catheterization, and have very few adverse events, and the outcome is pretty comparable to the invasive. So, the different types are, lasers, radio waves, ultrasound, microwaves, electrical current, and we'll talk about a few. The microwave therapy, or the 2-month, is outpatient procedure. It delivers the microwave directly into the prostate, so it kind of heats the tissue and causes death of tissue. So it kind of heats it, swells it up. So they always put a catheter in place because it's going to swell up, and once it cools down, it's going to shrink the tissue to become smaller, and it tends to, like if you put a biscuit in a microwave and you heat it, it swells a little bit, but if you heat it too much, it shrinks and it becomes, hard and small. And that's basically what it does with the tissue. It heats it up, it destroys it, and then it shrinks in a few days. So they usually put in a catheter for a few days and then remove it a few days later. The patient is usually sent home with the catheter for, up to a week. They usually give them medication like pain medication, antibiotics, to, make sure they get through the process. It's the side effects can be bladder spasms, hematuria, dysuria. If they do have bladder spasms, they can give them something like Uracet is probably more common with urology, but we do have to tell them that it turns the urine a bluish green, so that they, make sure they know that they're not a Martian, they hadn't turned into anything. And of course, Peridium can be used as well, and it turns it orange red. But they tend not to use Peridium because they want to make sure they know if they're having any bleeding issues, and Peridium tends to mask that sometimes, so they usually don't use that. Tuna, the needle abulation. Only the prostate tissue in direct contact with this needle is affected. This allows a greater precision of the removing of the targeted tissue. The extent of the tissue removed by this process is determined by the amount of tissue that's in contact with the needle. The laser prostatectomy delivers a laser beam transurethral to cut through the destroyed part of the prostate. Common procedure, visual laser ablation of the prostate. This can take several weeks to reach optimal results. And it's a variety of laser procedures or sources and wavelengths that can be used. A TURP, which is a transurethral resection, is removal of obstruction prostate tissue using a rectoscope. And they have a pretty good outcome. It's pretty 80 to 90%. Low risk factor. The bladder is irrigated for the first 24 hours to prevent blood clots because they do have bleeding. So a catheter is put in place with an irrigation system, and you've probably seen this in the hospital already. But they will keep that irrigation steady flowing to prevent the clots from, blocking off. And that catheter also maintains a pressure on that site to decrease the risk for hemorrhage. Nursing assessment, you're looking at incontinence, dysuria, sensation of incomplete voiding. This is going to be some of the norm that you see post the catheter removal. As far as the nursing assessment, looking at the adult male, because only male is going to have issue with this, is you want to make sure that their bladder is not becoming distended. Even when they're on the catheter, you want to make sure it's not blocked. If they're on that irrigation, you want to make sure it's free flowing, that it hadn't stopped up, and then you may look at that urinalysis as well. Pain and infection are your nursing diagnosis. Pre-op care for a TURP is, pre-op, they usually have a catheter in place. A coude is just a curved tip catheter, and a filiform is a firm catheter or rigid. Administer antibiotics in many of your healthcare settings. A lot of times they'll use lidocaine gel to put in your urethra before they put that catheter in, so that it numbs the area. You really want to pre-op, cover your questions with your patient, because you want to make sure that your patient understands what's going on with them and what the outcome that's expected, and any complications that can possibly happen. You want to make sure. And so, you inform your patient of, from things from the complications, to infection, to sexual functioning after. They're going to need to know that information. The plan of care should be adjusted to what type of surgery they have, and the reasons for surgery. So you need to develop the plan of care, based on that. But make sure that you're assessing your patient, looking out for complications such as hemorrhage, bladder spasms, urinary tract infections. Post-op, we talked about bladder irrigation. It's going to be a continuous process for at least 24 hours. Could be longer if they have a lot of clots in there until it kind of clears up. Give them the antispasmodics such as Uracid, and teach them Kegel exercise. These are things that they can be working on. And, it's very important that you use aseptic technique when irrigating that bladder, because bacteria can easily get in and be introduced to that urinary tract. So you want to be able to pay attention to that. After surgery, make sure they know that they're going to have a indwelling catheter, and then after the catheter comes out that they're going to have issues with incontinence. You need to be able to tell them that, because it can take up to a couple months for that bladder to get back to normal. They need to drink 2 liters of fluid a day, and urinate every 2 to 3 hours to keep that urinary tract flushed out once that catheter comes out. Prevent constipation, avoid heavy lifting, usually not more than 10 pounds, and refrain from driving or sexual intercourse until their healthcare provider lets them know that it's okay. Male reproductive orders, I got a few slides on this. We're going to cover some of this, and the first thing we're going to talk about is erectile dysfunction. Erectile dysfunction is the inability to obtain or maintain an erect penis. Causes can be diabetes, trauma, stress, depression. We do diagnostic labs. We can do a DRE. The labs may consist of testosterone and hormone levels, as well as FSH, LH, all the hormone levels. Drug therapy, Viagra, Levitra, Cialis can work. There are other devices like urethral suppositories can be used, such as Muse. Vacuum devices can be used where they can actually pump up the penis. And then they can do intraurethral implants as well. Cancer of the penis is common in men who have had HPV and men who have not been circumcised. Treatment is radical resection and remove the growth. Radiation, chemosurgery, it depends on what the disease process is. It can be a collaboration of different treatments. Epididymitis, the most common cause is usually STI or some type of infection or trauma, or it could be UTI. STDs are usually the most common cause. Treatment is antibiotics. Swelling can last for months after treatment, depending on how bad it is. Orchitis is a bacterial or viral infection of the testicles. If it's bacterial, then antibiotic treatment is necessary. Some other acquired problems are hydrocele, which is a fluid-filled mass. Is no treatment unless symptoms require it. Your varicocele is a dilation of the veins or varicose veins in the area in the genitalia. They can do injections of sclerosing agent or surgical ligation if required. Testicular torsion is a twisting of the spermatic cord. This is considered a surgical emergency. We see this more prominent with athletes or people that are very active. This is a question the nurse is caring for a patient after a radical perineal prostatectomy for advanced cancer for the prostate, which is a priority nursing diagnosis for this patient. This last question is, he's scheduled for a TURP. When you assess the knowledge and procedure and its effects, you realize need for further teaching. And, keep in mind, retrograde ejaculation is common with transurethral resection of the prostate because of the trauma to the urethral sphincter. If retrograde ejaculation occurs, the patient may be sterile after procedure. The catheter is removed 2 to 4 days after surgery, and erectile dysfunction is unlikely with a terp. And this is the end of this lecture.